everyone. My name is Sajel, as most of you already know. I'm a second-year PEDS resident, and today we're going to be talking about something I've become pretty involved with this year, Group B strep. It has nothing to do with genetics, don't worry. But it is really interesting, so I hope you think so too. We're going to focus a lot on the research aspect of it at the end, a study that we're working on, but the beginning of it, probably the first half, will be the history of GBS and things that hopefully you didn't know before and that you'll learn today. So I have no relationships to disclose with the industry. The goal of this talk is to raise awareness of GBS disease. We know about it a little bit, you know, our babies, we don't want them to get it from mom, we know that it's bad, but as far as that, I mean, those are one of the things that I didn't really know much about, and so this is something that I think other people don't know much about either. So the objectives of this talk, at the end of this session, we should be able to describe the clinical significance of infections with GBS, to discuss the epidemiology of GBS colonization in pregnancy, to review the current guidelines for screening pregnant patients for GBS, which is important because you'll know if your mother was correctly screened, to identify known risk factors for maternal colonization with GBS, which is important because then you'll know if your baby had a chance of having a mom with GBS, and to discuss the significance of antibiotic resistance in clinical GBS isolates. So this is important with drug resistance as time goes on and the antibiotics are used to treat these moms and these babies. So the outline of our talk today, first we'll talk about what is GBS, and then we'll touch upon special populations, the history of these infections, risk factors for these infections, and then we're really going to focus today on the 2010 CDC prevention guidelines, and then GBS infections and STIs, because as you all know, we have a lot of STIs in our population. And then we'll talk a little bit about some future directions in case anyone else is interested in doing research on this topic also. So Group B Streptococcus, also known as Strep A. galactiae, and a GBS is a gram-positive beta-hemolytic cocci. It causes invasive disease in infants, pregnant women, and older adults. It doesn't really discriminate to any particular population. But what surprised me is in non-pregnant adults, it's become increasingly recognized as a cause of bacteremia without a focus, sepsis, soft tissue infections, and other focal infections. And they think this happens because of a loss of barrier protection in a chronically colonized site. So the epidemiology of this, it affects about 4 to 7 in 100,000, 26 in 100,000 patients over the age of 65, and accounts for 90% of GBS mortality in the United States in this population, and over 3/4 of invasive GBS disease in the US. Our perceptions are a little bit skewed because we don't really work with this population, so I thought that was interesting. We have a 15% case fatality rate amongst the elderly, and it affects men and women equally. And then in this population, it's seen more in African Americans than in Caucasians, which kind of goes across the board for all populations. Risk factors, you think of your immunocompromised patients that have diabetes, advanced hepatic and renal disease, malignancies, HIV, nursing home residents, and some studies, but not all, have shown alcoholism, cardiovascular disease, collagen vascular disease, and trauma to be risk factors as well. So these are sometimes, and these have been shown consistently to be risk factors for GBS. But no obvious immunodeficiency is common to patients with these conditions. You are 3 times more likely to have GBS with diabetes, and you're 10 times more likely to have it with cirrhosis. And between that, you see 4 times more likely with stroke, breast cancer, decubitus ulcers, 5 times more likely with neurogenic bladders, which makes sense because these can be areas of chronic colonization. So in pregnant women, GBS is a common colonizer of the GI and GU tracts. It's asymptomatic. It's not an STI, although some studies looking at the rectal carriage of homosexual males, say that it may be sexually transmitted. They found percentage carriage rates as high as 25%. This colonization comes and goes in these women, which makes it really difficult to detect clinically, because right now we only test them during certain times of their pregnancy, but just because they're negative at 35 to 37 weeks doesn't mean that they were positive before, or vice versa. So it's a frequent cause of UTIs, choreo, postpartum endometritis, and bacteremia in these moms. It affects 10 to 30% of all women, and also African Americans greater than Caucasians, greater than the Hispanic population that they studied. And a strong risk factor for early onset GBS disease in infants is maternal colonization with GBS during labor and delivery. So how does mom pass this to her baby? We don't really know, but we know that if a mother is colonized with GBS, she has a 50-50 chance of giving it to her baby, and then that baby will have a 2% chance of exhibiting symptoms of early onset sepsis, pneumonia, or meningitis. So this is probably a very later study. Why do these babies have these symptoms and not this 98% of babies? But that, I hope someone finds out one day. That would be very helpful. So GBS in infants is acquired in utero or during passage through the vagina. The most common manifestations of this, as you see in the non-pregnant adults, are bacteremia without a focus, sepsis, pneumonia, meningitis. And risk factors that have been shown in previous studies include preterm delivery, prolonged rupture of membranes, maternal choreo, a previous infant from the same mother with GBS disease, low maternal levels of anti-GBS antibodies, African American and young maternal age mothers, and moms with GBS bacteriuria during pregnancy. So the history of GBS, this I thought was interesting. So in the 1930s, it was recognized as a disease-causing organism in humans. Only 40 years later did it become recognized as the most common cause of sepsis and meningitis in infants younger than 3 months of age. And at that time, it had a 50% infant case fatality rate, which is alarmingly high. And so in the 1980s, they started to do these clinical trials with antibiotics to introduce intrapartum antibiotic prophylaxis, which we know as IAP, to try and prevent this infantile disease. They did studies with penicillin and ampicillin, and they gave these to GBS colonized pregnant women. I mean, they didn't really have risk factors that they wanted to go by, and so this was just a start, which did show a reduction in infant colonization and a reduction in infant disease. So we were getting somewhere by the 80s. And then in 1996, they came up with the consensus guidelines for GBS prevention. There were two approaches, a screening-based approach and the risk-based approach. They were a little bit different. I've underlined those areas where they differed and then where they were the same. So in the screening-based approach, they did a rectovaginal culture at 35 to 37 weeks, and they gave IAP for GBS carriers for preterm delivery unless they've had a negative culture already, for GBS bacteriuria during pregnancy, and for a mother with a previous infant with GBS disease. The risk-based approach, they did not do a rectovaginal culture. They only gave IAP for preterm delivery for prolonged rupture of membranes greater than 18 hours or intrapartum fever, for GBS bacteriuria during pregnancy and previous infant with GBS disease, which was the same in the screening-based approach. So by that time, 48% of women were screened and 74% of women who needed IAP got IAP. So still better, we're getting better. And then in 2002, they made intrapartum antibiotic prophylaxis. Okay. In 2002, key changes were made to the GBS guidelines, where there was universal screening by rectovaginal culture at 35 to 7 weeks. Everyone was getting it done. And the intrapartum antibiotic prophylaxis, were penicillin preferred or cefazolin for penallergic patients. There was no routine IAP for planned C-sections, and they would screen and give IAP for threatened preterm deliveries. So there was more detail on specimen collection and handling, which is important because the lab, if they culture and handle your specimen appropriately, then you'll know if your patient has GBS or not, and that'll reduce your false negative rate also. And also there were guidelines that focused on neonatal management. They added choreo to that. And this resulted in, I mean, this is impressive, 85% of women were screened and 85% of women that needed IAP got IAP. So we're doing better in 2002. And then in 2010, our case fatality rate dropped to 5%. This is way better than 50%. And new guidelines were established. We'll talk about those later because those are important, especially because those are what we're going by now, and I think everyone needs to go over those. So early onset GBS, it's the leading infectious cause of neonatal sepsis in the United States. There were about 1,200 cases in 2008, and most cases of early onset GBS now occur in infants born to women who screened negative in pregnancy, and this is because of false negative prenatal screening results, and then they were never treated. So clinical presentation symptoms occur as early as day 0 of life, and in 80% of cases they present with bacteremia. In other cases they may present with respiratory distress, apnea, sepsis, pneumonia, and meningitis. Yes.
You may want to define what is early onset, what is late onset, late onset. These are arbitrary.
So early onset is in the first 7 days of life. Late onset is within the first
7 days to 90 days.
7 days to 90 days, and then late onset is after 90 days. So we're not talking about late onset today, but we'll talk about a little bit about late onset and also early onset. So this is Dr. Pranik's favorite graph. This one shows that the cases per 1,000 live births of early onset GBS disease in 1990 was almost 2 cases, 1.8. And with the CDC guidelines and the consensus guidelines, and you see here where you're doing universal screening, that number has plummeted. It's 0.4 and dropping. So there was success on that point. And the prevention, as we already started to talk about a little bit, intrapartum antibiotic prophylaxis, it's highly effective at preventing early onset GBS, as you saw from that graph. It had 100% efficacy in clinical trials and 86 to 89% effectiveness in observational studies. So this graph superimposes late onset GBS onto early onset GBS, and you see that the rate really hasn't, the cases really haven't dropped. So whatever we're doing is not working for that. So that's important. Just keep that in mind, and that is something that we'll come back to towards the end of the presentation. So the CDC 2010 guidelines, so the key strategies that remained unchanged, so we're still doing universal screening, and we're still doing IAP and preferring penicillin to this. So we're giving IAP if moms have a positive GBS screen, if moms are GBS unknown and deliver preterm, have fever during labor, or prolonged rupture of membranes, for a previous infant with GBS disease, and for a mother with GBS bacteriuria at any time during her current pregnancy. This GBS bacteriuria is in about 2 to 7% of pregnant women. This is a marker of heavy rectovaginal colonization, because what we think right now is that GBS is colonized in the GI tract. And so to move forward to the urinary tract, it's thought that there are a lot of bacteria that is how that happens. So this is a risk factor for early onset GBS disease in the newborn, and antibiotic treatment of your GBS bacteriuria during pregnancy does not eliminate GBS colonization from the GU and GI tracts. As we talked about before, the colonization is dynamic, and so most of these moms can recolonize also. So we don't give prophylaxis for if moms have had GBS colonization in their previous pregnancy or bacteriuria in their previous pregnancy. That's not a requirement to give prophylaxis in her current pregnancy. If during her current pregnancy she is GBS negative via her rectovaginal culture, or if she has a C-section that's performed before onset of labor with intact membranes, regardless of her screening status or her gestational age, she does not require IAP. So GBS screening, the way that we do the culture, it's a rectovaginal swab between 35 and 37 weeks. The lab cultures a specimen on appropriate media, and they use an enrichment broth for maximum sensitivity, and so it becomes optimal to detect the bacteria. It's very important to notify the lab of a patient's beta-lactam allergy because they can run sensitivities on that culture. And then you'll know what antibiotics will be appropriate to use for that mom. So they do something in the lab called the D-zone test. This is an antimicrobial susceptibility testing for these women that are allergic to penicillin and that are at a high risk for anaphylaxis. So this is going to test for something called inducible clindamycin resistance. That just means that your GBS strain has become resistant to clindamycin. Why, we don't know, but that is something that does happen. And normally GBS has exquisite susceptibility to beta-lactams, but many isolates from invasive GBS disease were shown to be resistant to clindamycin and erythromycin. So that is a problem with the emerging use of antibiotics that we're coming to. So this is a positive D-zone test. You see this line here. This shows you blunting of your inhibition zone. This is clindamycin. And so this is showing you clindamycin resistance because this clindamycin is not wiping out this sample anymore. So just to go over the algorithms again, IAP for women with preterm labor. If your mom comes in with signs and symptoms of preterm labor, she needs to be swabbed and cultured for GBS and prophylaxis is started. If she's entering true labor, then her prophylaxis continues until delivery. If she's not entering true labor, then we can discontinue prophylaxis and obtain culture results. If those culture results are unknown or positive, then at the onset of her true labor, she is started on GBS prophylaxis again. If those culture results are negative, then she does not get prophylaxis at the onset of her true labor, and her culture is repeated if she reaches 35 to 37 weeks and hasn't been delivered. For moms with preterm premature rupture of membranes, the mom comes in with preterm premature rupture of membranes. We obtain a culture and start antibiotics for latency or for prophylaxis. If the patient is entering labor, then we continue antibiotics until she delivers. If she's not, we continue antibiotics and obtain culture results. And if these culture results are unknown or positive, then she gets prophylaxis at the onset of her labor, as we saw in the last algorithm. If these results are negative, then she does not get prophylaxis, and we repeat the culture if she reaches 35 to 37 weeks, as was in the previous slide. So antibiotics. The 2010 GBS guidelines for selecting the antibiotic regimen is the first question you're going to ask is your patient allergic to penicillin? If she's not, the preferred drug is IV penicillin G. And the first dose is 5 million units, and then the dose every 4 hours after that is between 2.5 to 3 million units. Or ampicillin, which we give 2 grams IV for the first dose, and then 1 gram every 4 hours after that. And these are all until delivery. So if your patient is allergic to penicillin, the next question you want to ask is, does she have a history of any of the following after receiving a penicillin or a cephalosporin? Anaphylaxis, angioedema, respiratory distress or urticaria. If she does not have any of these symptoms, then we can give her cefazolin 2 grams once and then 1 gram every 8 hours after that until delivery. If she does have a history of any of those symptoms, then we ask, is the isolate susceptible to clindamycin and erythromycin? If it is, she can get clindamycin, 900 milligrams every 8 hours until delivery. And if it's not susceptible, she gets vancomycin, 1 gram every 12 hours until delivery. So that's a breakdown of the antibiotics that we use. So as I said before, that's great. but the resistance has increased. In 2001, we were 25% resistant to erythromycin, and now we're almost 50% resistant to erythromycin. And the same with clindamycin. It was 11% in 2001, and now it's almost 25%. So, the CDC 2010 guidelines on newborn management, revisions from previous guidelines is that this applies to all newborns, whether or not the mom received IAP. Management is based on their clinical appearance, their risk factors, and the adequacy of mom's IAP. Risk factors include maternal choreo, prolonged rupture of membranes, and preterm labor and delivery, a lot of our NICU babies. So the adequacy of IAP is when mom received IV penicillin, ampicillin, or cefazolin at least 4 hours before delivery. So this is a diagram that shows the secondary prevention of early onset GBS disease among newborns. This is briefly the steps that you take in your head when you're getting this new baby that's born. Does the baby have signs of neonatal sepsis? Yes, you're going to do a full diagnostic evaluation and start antibiotics. If they don't, you ask, did mom have choreo? Yes, she did. You still give antibiotics and do a limited evaluation. If it's still no, did mom need GBS prophylaxis? If she did, you ask, did she have adequate IAP? And if she did or did not, you're going to observe for at least 48 hours. But if that baby was term and did not have prolonged rupture of membranes, then you don't have to do any more than observe, but you're more likely to do that if your baby was preterm and mom had prolonged rupture of membranes. So that can get far more detailed, and you could do a whole lecture on that. But I found this. There's an app for that called PreventGBS. It was developed by the CDC in tandem with the American College of OB/GYN, the AAP, the American College of Nurse Midwives, and the American Academy of Family Physicians. This is a evidence-based recommendation kind of guideline where you can enter, you go through basically this entire algorithm for babies, or you can go through one for moms, and it'll tell you these are the antibiotics you should use based on these guidelines. So they have for the neonatal provider, they have it for the OB provider, and they have just the antibiotics if you want to look at those. So this is the first slide. It starts out, does the newborn have signs and symptoms of neonatal sepsis? So you'll pick yes, no, and then move on to the next slide. I really like this app. I just found that last week. So these are also some things I found. You guys have seen other cards that people have found in different presentations. Greetings on the go. You can send these to up to 8 people. I don't know why you would want to send them to 8 people at the same time. But have you heard, if you're 35 to 37 weeks pregnant, ask your doctor or nurse about getting a Group B strep test. So if you know anyone, you can send them these e-cards anonymously or otherwise. And so back to this slide. This is no bueno. This is not good. So all of the things that we've done, these prevention policies, the universal screening, the guidelines, we've made a great effort at decreasing the rate of early onset GBS, but we haven't done much for late onset GBS. So we still don't know why these babies get late onset, why they get GBS at all. If we knew that, then we could prevent the transmission of GBS, and that would surely do something about this. And so this kind of brings me to the research that we're doing to try and find out why moms get GBS in the first place. And since the invasive GBS isolates are clinda and erythromycin resistant, what does that mean? Where is that coming from? So we did a study, we've been doing this over the past year. It's called Antibiotic Exposure and Sexually Transmitted Infections as Risk Factors for Colonization with GBS in Pregnancy. So the purpose of our study was to determine whether there's an association between antibiotic exposure during pregnancy and GBS colonization, or the presence of inducible clindamycin resistance in GBS isolates from these GBS colonized pregnant moms. So what we did was a retrospective paper chart review of 1,500 paper charts, which was daunting. And these were women that were screened for GBS between July 1st of 2009 and December 31st of 2010. And we collected data on several points. We got age, gestational age, maternal age, height, weight, all infections that were documented, what antibiotics they had gotten, whether they were for STIs, whether they were for UTIs, pneumonias, for whatnot. And the number of prior pregnancies, moms, GBS screening results, and we had, thanks to Dr. Capraro, their antimicrobial susceptibility profiles, so that helped a lot. Our p-values were significant when they were less than 0.05. We did the analysis online using BESAR stats. So this is what we found. Table 1, this is clindamycin resistance of GBS isolates. So out of our 1,500 patients with GBS, we had about a third of them were screened positive for GBS. 1/3 of those patients were clindamycin resistant, and what was pretty high is that 2/3 of those patients had inducible clindamycin resistance. So that, in previous studies, the highest that was shown was 11%. So 24% is a lot higher than that. This is another table, association of race and age with GBS colonization and inducible clindamycin resistance. So in previous studies, we had shown that African American race is a risk factor for being colonized with GBS. We proved that also. We showed that our odds ratio, you are 3 times more likely to be colonized with GBS if you're African American than if you're not. So that is what we got from this table. Table 3, association of antibiotic exposure with GBS colonization but not inducible clindamycin resistance. So patients that were exposed to antibiotics, this is any antibiotic, not just for STIs, but for UTIs and for whatever they were treated for, were almost 2 times more likely to be colonized with GBS. This is not clinda-resistant strains, this is just GBS in general. And then GBS colonization and inducible clindamycin resistance among subjects with STIs. This is subjects, patients that had STIs were 2 times more likely to be colonized with GBS, which is significant for our population. But those, again, that population is not going to determine whether or not that strain is clinda resistant or not. It just is a risk factor for GBS colonization in general. So the STIs that we looked for included chlamydia, gonorrhea, herpes, HPV, syphilis, BV, and trichomonas. And this is an interesting slide. This is the STI percentage in our population, which is pretty high. We've got 22% of patients had chlamydia, 20% had trich. We have 2.4% had syphilis. Our population is only 1,500. Usually they determine the percentage of syphilis in a population per 100,000. So table 5, this is GBS colonization and inducible clindamycin resistance among subjects with STI and azithromycin exposure compared to subjects with STI and exposure to other antibiotics. So if you had an STI, if these moms had an STI and were treated with azithromycin, they were not any more likely to have GBS, but if they had GBS, they were more than 3 times more likely to have a clinda-resistant strain. Why is that? We'll talk about that a little bit towards the end of the presentation because we really don't know, but we can make a hypothesis for a future study that can be done. So in this table, GBS colonization and inducible clindamycin resistance among subjects with chlamydia compared to subjects with other STIs. If the mom had chlamydia and not any other STIs, then she was not more likely to be colonized with GBS, but she was more likely to have a clinda-resistant strain. Is that because she was treated with azithromycin? Maybe, but we can't say that yet, but that's a good hypothesis to make. Association of inducible clindamycin resistance with chlamydia infection is, as I said, you're 4 times more likely to have inducible clindamycin resistance with a chlamydia infection than you are without one. So, association of inducible clindamycin resistance with azithromycin exposure. If moms had azithromycin and their strains were tested for inducible clindamycin resistance, they were almost 7 times more likely to have a clinda-resistant strain. And so, are these babies that are getting GBS disease coming from moms who are treated with azithromycin for something? I mean, that's an interesting thought. And that's what I'll leave you with. We'll talk about some of the things that we found from our paper. Significant associations of GBS colonization. Previously in studies that we also showed in our study, African American race and prior GBS colonization. And then these are all novel findings. These were never documented in any other papers. STIs during pregnancy, antibiotic exposure during pregnancy, and this is in general. Clindamycin and chlamydia infection, clindamycin resistance and chlamydia infection during pregnancy, and receiving azithromycin during pregnancy. There were no associations of GBS colonization with maternal age and BMI. Previously, they had said young maternal age was a risk factor, but our population was so low that we could not find significance in that. And there were no associations of clindamycin resistance with maternal race, maternal age, just general antibiotic exposure, STIs, prior colonization, or whether mom was a preemie-gravid or a multi-gravid. So food for thought. This is maybe what's happening and something to explore in the future. Azithromycin may exert a selection pressure on GBS. There are 2 genes, the ERMA and the ERMB genes, that have been previously shown to mediate something that's called macrolide lincosamide streptogrammin resistance in GBS. They've shown that this leads to inducible clindamycin resistance in these strains, and azithromycin may be a way of turning that gene on to make these strains inducibly clindamycin resistant. So future directions are to determine the contribution of antibiotic exposure and STI to the likelihood of GBS colonization and clindamycin resistance, to do multivariate analysis on the data, and determining the clonal diversity of GBS strains in our patient population. Is the strain one strain? Is it multiplying, or is it several different strains of GBS that are resistant? Because that would give us a better idea of where that strain is coming from. And also to identify selective pressures that promote antibiotic resistance, because we don't know much about that yet. So that's that. You all look confused.